want to introduce myself. I'm Nick Turner. I'm the president of the Vera Institute of Justice, and to thank all of you for coming here today for this discussion and for the launch of our Justice Reform for Healthy Communities initiative. It's an initiative that aims to improve the health and well-being of communities that have been most impacted by decades of mass incarceration. Most importantly, what we're trying to do is to look at opportunities to apply a public health framework to address aspects of the criminal justice system that deepen social inequities and exacerbate health disparities. And thanks to the Affordable Care Act, there are many more of these opportunities to focus on. This work, for many of you who may know Vera past and current, is a very logical next step for us. We have been sort of plying the intersection of justice and health systems for quite some time for the betterment of disadvantaged communities. As many of you may know from spin-off projects that have grown to be independent nonprofits like the Legal Action Center and Project Renewal. This is an area of work we've been in for some time. Our work on substance use and mental health in the last few years has really set the platform for what we're doing today. And we come into this work with a sense that national health care reform efforts under the Affordable Care Act, combined with national, state, and local and civic leaders who are seeking to figure out ways to reduce incarceration and to provide ideal opportunities for people, provide us an ideal opportunity to build on this collection of work. And I want to pause for just a second because as I was talking to Robin Steinberg, who is one of our advisory board members of this initiative, just a moment ago, I was reflecting on what I've really observed as a change in the environment, a change in attitudes, both in terms of citizens who you would not expect and public officials to tackle what many of us describe as mass incarceration, or otherwise known as sort of an over-reliance on incarceration as a way to deal with criminal activity or a set of activities that may not even rise to the level of criminal. And just this, in the past 3 weeks, there have been three phenomenal examples of that. George Soros put $50 million into the ACLU to make mass incarceration an issue in the upcoming 2016 elections. That is an unheard of investment in this issue and to try to move the debate and move the needle forward. About 10 days ago, Tina Brown, you say? Yes, Tina Brown of the Daily Beast and formerly of the New Yorker, hosted the American Justice Summit, which was a half-day-long event that really sought multimedia event that sought to explore the challenges of providing justice in this country. And for some reason, she really has found religion on these issues. And then just on Monday, Neil Barsky, who is a former hedge fund manager, and Bill Keller, the former capo di tutti capi at the New York Times, where our moderator works, launched something called the Marshall Project, which is essentially a ProPublica intended, an enterprise journalism effort tended to focus entirely on criminal justice matters and to move the issues that many of us in this room who work on to the front of the agenda. That doesn't mean that the challenges don't persist, but it certainly means that there's new capital and new attention and new momentum in this area, and that's what we're all riding. And the important thing to really think about is that when we think about how to constrain or improve the way in which the criminal justice system has dealt with a range of issues that are often behavioral, that are health issues. We can think about how to roll those things back, but it's equally important, and really more important if we're concerned about healthy communities, to think about what the right framework is for dealing with a set of issues that really are health issues. And that's why we find ourselves here today and why we're launching this effort. All of you found on your chairs the fresh off the presses release of On Life Support, Public Health in the Age of Mass Incarceration, which is a publication produced by my remarkable colleague, David Cloud, who will now give a wave to the audience. There he goes. And this initiative and David's paper are really taking on a national issue. But it's a national issue that really plays out in real time and in big time here in New York City. Because when it comes to public health, I think it is fair to say that New York City's Department of Health and Mental Hygiene, which is led by Dr. Mary Bassett, who is sitting to the left of David, is really the nation's, if not the world's, sort of rock star department when it comes to public health and dealing with challenges that have long bedeviled us. And New York City's criminal justice system is one of the most watched in the nation, as we know. And so we're thrilled that not only with Dr. Bassett, that Liz Glazer, who leads the mayor's office on criminal justice, is joining us today. And she is there on the end, as is Barry Campbell, next to her, who works with formerly incarcerated individuals at Fortune Society. And together, all of them will talk about the intersection of criminal justice and the public health systems, and how criminal justice has a huge impact on the health of communities. The bios of everyone, I could go into greater depth, but you'll see we're also on your seats as well. Note, I don't know if anyone in this room dares to do it, but we are live tweeting here at Vera. This is what we do at Vera these days, because we are firmly in the 21st century, until the next social networking app or whatever the thing is comes along, and then we'll be doing that as well. And so it is hashtag justice and health, and we invite you to join in that conversation. So to lead the discussion, we're honored to have Jesse Wegman, who is right here to my right. Jesse is an editorial board member of the New York Times, which he joined in 2013. Prior to that, he was a senior editor at the Daily Beast and Newsweek, a legal news editor at Reuters, and the managing editor of the New York Observer. In 2010, I think it was, Jesse, you received a Soros Justice Fellowship to write a book on jailhouse lawyers, and Jesse graduated as a lawyer himself, or soon. Did you ever take the bar and pass it? Okay, sorry, that could have been embarrassing. That was not in the talking points, but I just sort of went off script for a while. From New York University School of Law in 2005. So I'm going to turn things over to Jesse. Thanks very much for everyone being here, and looking forward to a great panel.
Thank you, Nick. I did graduate from NYU Law, and I did take the bar, and I did actually get admitted to the bar, and then I never practiced, and I retired. And about 6 months later, so I didn't have to pay the annual fee, and when I called to retire, the woman congratulated me on my career. I said, "You have no idea." I'm really thrilled to be here, and I appreciate Vera for inviting me. Vera, I've been a friend of Vera's for at least 10 years. I was just recounting with Nick coming in here back in the early 2000s looking for a job. And I just think what Vera's been doing for a very long time is some of the most important work in social justice that can be done in this country, and the rest of the country is only just now coming to understand how important it is. And I think under Nick's leadership, it's going to become one of the most important points of light, as it were, in the country on this issue. I'm also happy to be here on specifically on this topic. I come from a public health family. My father and my his father are both lifers in public health, and I think they always wondered or sort of wished that I had gone into public health, and I never leaned that way. But if anyone, I don't know if my father has a Twitter account, but if anyone wants to like tweet to him that I'm here just to prove, I just will feel like I've done some good. So I think just to begin, I just want to sort of set the stage here. I think there are so many ways to talk about the destructiveness of this country's 40-year experiment in locking up millions of its citizens. And we're going to focus tonight on the one that hasn't before now gotten too much attention. I think, as David and his colleagues have been saying for a while, mass incarceration poses perhaps the greatest public health challenge of our time. For many obvious reasons, people in prison are among the unhealthiest members of society. If they're not already unhealthy when they enter, they're likely to be worse off when they leave. In particular, rates of mental illness and drug abuse among prisoners are many times higher than the general population. The report shows that more than 2/3 of all inmates have a substance abuse problem. Meanwhile, our practice of sweeping vast numbers of largely black and brown men and dropping them behind bars has profound health effects on the communities that they come from and that most of them return to. These include poverty and homelessness and poor nutrition and lack of medical care and the shattering of families and on and on. In his excellent book, A Plague of Prisons, Ernie Drucker tried to quantify the effect of mass incarceration in the language of epidemic disease. By one epidemiological measure, potential years of life lost, he calculated that in New York State alone, since the early 1970s, drug offenders have lost close to 400,000 potential years of life to prison. So how do we stem this epidemic? As everyone on tonight's panel can talk about from a unique angle, there is a profound disconnect between our correction systems and our public health systems. This isn't just left hand not talking to the right hand. This is often there are no hands at all, I think. But by the same token, 2014 is a very different time than 1984 or 2004 or even 2010. There's been, as Nick was just pointing out, a dramatic growth of interest about the consequences of mass incarceration. And just as important, I think, an agreement across the political spectrum that the course we're on is not just unsustainable, but destructive to the fabric of the country. I would add to Nick's list of notable recent developments in the world of criminal justice that the Koch brothers just gave a sizable donation to the National Association of Criminal Defense Lawyers to develop better research and information on indigent defense throughout the country. Now, it wasn't $50 million, but it's the Koch brothers, so that's meaningful in its own way. But to add to that, when I write editorials quite often on the issues of criminal justice, and I'm finding myself constantly in conversation with well-meaning people of all political stripes who just want to make this situation better. And it's a remarkable moment that we're in, and it may not last very long. So with this in mind, I want to get this conversation started among the panelists and then open it up to the audience for a broader conversation. It can be, it can be a very interactive experience. You have the bios, but I'm just going to very quickly introduce them. David Cloud, to my right, is the Senior Program Associate for Vera's Substance Use and Mental Health Program, and he's also the author of the paper that spurred tonight's event on life support. Dr. Mary Bassett, as everyone probably knows, is New York City's Health Commissioner. Barry Campbell, to her right, is a Special Assistant to the President and CEO of the Fortune Society, and himself someone who can speak from personal experience about the health consequences of being incarcerated. And then Liz Glazer on the end is the director of Mayor de Blasio's Office of Criminal Justice. So thank you all for being here. And I want to, I'll start with David, and I would like David, for those of you who haven't had a chance yet to look through the paper, the report, I'm sorry, which is really remarkable in its comprehensiveness, is to give us some of the bigger picture in numbers. What is the scope of the public health crisis that mass incarceration has bequeathed us?
Sure. So thanks very much, Jesse. So the first part of the paper is really about raising awareness to kind of an unforeseen consequence of mass incarceration. If you're diving into the numbers, you compare prevalence and incidence of rates of mental health issues, substance use, infectious disease, chronic disease, and a range of other issues to the general population. And there's some nifty infographics in the report that kind of just put them right in front of your face. And just to be brief about it, they're just disproportionate. And I think that's something that we don't notice. I think it's something that's detached from our health departments, from the infrastructure that's responsible for surveilling the burden of disease among our population. So many other things among incarceration populations follow the same kind of theme, but it's not out in the purview of the public or the government.
So can you give some data just
Sure.
to bring people up to speed on the scope of
the one we deal with a lot is mental health and substance use. So approximately 14.5% of men, 31% of women have what is a serious mental illness. That includes things like bipolar disease, schizophrenia, major depression, and that's alarmingly much higher than what you see in the general population, which is around 3 to 5%, respectively. 2 to 7% higher rates of HIV and AIDS. Approximately 17% of people with HIV or AIDS pass through correctional environments each year.
One of the central points of the paper is the failure of these two systems, public health and corrections, to really effectively communicate with each other. Talk more about that, would you?
Sure. So I think a lot of it has to do with there is a constitutional right to health care when you're there. I think it's important to keep in mind that constitutional right is the Eighth Amendment. I would never buy an insurance plan that said, I'm going to give you a right to your health care, but it's based on the fact that I'm not going to be cruel and unusual to you. And that's just part of it. So, I mean, there's not surveillance. The standard of care in correctional environments is not as good as it is in the community. It's detached from the culture, the ethics, the technology, everything else, all the advances we've made in mainstream health. They're lagging in correctional environments. Some of it has to do with the organization. So New York City is fortunate to have the health department at the table in the same room as the justice folks, keeping an eye on things, setting up things like electronic health records. I mean, those things are critical. But in most places, that doesn't exist, and there's just fundamental disconnect. There's no data. There's no continuity of care. We know that when people are about to be released from facilities, there's excess mortality. It's one of the most dangerous times is, you've been, especially if you have a drug addiction, you've come into a system, you've been off a substance for a while, your tolerance goes down, you're about to go back into the community without some kind of handoff, some kind of effort, some kind of in-reach and engagement. Your risk of death, disability, suicide, all those things are significantly higher.
Great. Dr. Bassett, I wanted to ask you, when we spoke the other day, you said an interesting thing. You said incarceration is part of the neighborhood health experience. Can you talk about what you mean by that?
Sure. So, gosh, there's so many things to talk about. I want to first commend you, David, for writing this and for putting this issue center stage. So New York City is a city of neighborhoods, and these neighborhoods differ from each other in part because we're such a segregated city. We're segregated along race and income lines, and in this city, those are virtually overlapping. So that in this city, to be Black and Latino is pretty much to be poor, and vice versa. And I mean this not only conceptually, but actually technically. When we redid our analyses in the health department looking at race, which was something that wasn't looked at that often during the Bloomberg years, mostly low income was the metric. Only one zip code shifted. So when you look at health across the city, you see vast difference in the experience of health. And when you look at the sickest neighborhoods in our city, the ones with the most preventable mortality, and in some of our poorest neighborhoods, if they had the same mortality experience as our richest neighborhoods, half of the deaths would be preventable in these poor neighborhoods. So when you look at the health experience, and then you look at who's populating our jails and our prisons in upstate New York, they're the same neighborhoods. So what that means is that the communities that send people to jail, if we can use that phrase, it's not really an appropriate way of framing it, are the same communities that have the highest burden of disease, and the people who go through the experience of incarceration return to those neighborhoods. So that we really shouldn't consider the incarcerated population as people apart. These are populations that cycle through neighborhoods and really determine the ecology, particularly of our poorest Black and brown communities in the city.
Can you speak also about the impact on people when they are incarcerated, the larger health impact?
So as David mentioned, we in the city, the health department looks over the health care delivery services and view ourselves as the prison's doctor in the broadest sense, in the way that I consider myself to be the city's doctor as health commissioner. We consider ourselves to be the medical care officers for the jails. And that's an unusual arrangement. Often in many jurisdictions, the Department of Corrections actually runs. In some areas, the sheriff runs. Anyway, right. So we have this responsibility, and we take it very seriously, and we look not only at the conditions of health that you would think of. It still shocks me that nearly 60% of inmates report that they smoke when at intake, but also the experience of being in jail. And the experience of being in jail in our city jails is very often an experience of violence. And that's been one of the key things that I really, and some of the people in the audience today have participated in this work, so I want to acknowledge both members of our agency and former members. So the experience of violence is something that we're able to capture because we identify people with injuries in our medical room. We have an electronic record, which David mentioned, and members of the health department's teams have done a really good job at looking in particular at the impact of solitary confinement, used as a form of punishment. So we're also been able to do important work, I would say, in documenting the harm of solitary confinement to all who are subjected to it, including particularly young people and people with mental illness. So we have we think of it in two ways. We think of the population in the jails as people who are members of communities which we are most concerned about from a health perspective in the city. And we also think of the jail population as one that is experiencing a specific set of conditions in jail which can also affect their health.
Great, thank you. Barry, I'm going to come back to you in just a moment, but before I do that, Liz, I wanted to ask you to talk a little bit more about this idea. When we spoke on the phone, you used the term the hydraulic nature of the effects of mass incarceration on public health, in particular the pressure at one point affects the pressure at so many of these other points. Can you talk a little bit more about that and about how what role the administration can have in alleviating some of that pressure?
Sure. And maybe I'd like to just inject one slight note of optimism first. I join Mary in saying this was just an incredibly well done report, and I think sort of underscores issues that many people in this room have been working on for a long time. I think one thing that is interesting to note is that I think we're kind of living to some degree in an era of de-escalation, particularly in New York City and in New York State. So if you were to look now, at what's happened over the past 3 years, where the state has closed 11 prisons with enough beds that would be essentially what the prison population is of some of our smaller states, New Hampshire, Rhode Island, et cetera. That's an extraordinary thing. You look at Rikers today, It's virtually half the population it was 10 years ago. It's 1,000 less than it was, a year ago. But obviously, there's still much work to be done. We see those numbers coming down, but we need sort of more intentional action to drive it down. And so when I sort of think about it, I think about it very much, as Mary says, as this sort of system that isn't just about jails, isn't just about neighborhoods, but is about sort of an entire system. And so that when you think about how to begin to reduce the number of people in jail, the jails may hold up a mirror to things that are happening elsewhere. But we have to think sort of hard about how we stop people from going in at all. And that means we have to get better at identifying who, for example, the mentally ill are, how we have ways to off-ramp them from going into jails. When they're in jails, can we have better treatment so that they don't circle back? We see sort of number of frequent flyers, often the mentally ill, often the homeless, who come back through many, many times and are essentially sort of serving a life sentence, a few weeks at a time, right? So I think there is an opportunity, and this is sort of one thing that government should be good at, right? Is in sort of thinking about how all these different pieces of the system fit together. Can we have a better way of ensuring that people don't go in and ensuring that when they come out that they don't return? And to some degree that means sort of beginning to homogenize our systems better. So it's not just a public health system and a criminal justice system. Right now we're very good at incapacitating people. So 911 is, the call of first resort, which is the reason why a lot of people get picked up and caught up in the criminal justice system. We don't really have developed or haven't developed that kind of second muscle, right? Which is, what is the positive intervention? And why are we not as sort of molecularly understanding who's out there and what are those positive interventions that we can have to ensure that they never go into jail, or if they do and come out, that they never go back?
Great, thank you. Barry, I want to ask you, you're now at the Fortune Society, but you also served time in New York prisons. Can you talk about, from your experience, both inside and then as someone who had to reacclimate to society on the outside, what sorts of health, where you ran into trouble, what sorts of obstacles you faced in terms of taking care of your health?
First, I just want to thank the Vera Institute for bringing this information to the forefront. The funny thing about it is that people at Fortune and Osborne and WPA and Exodus, we've been having these type of conversations for decades now. The other thing I want to say before I start is that, please, I'm not intentionally trying to offend anyone, but I will speak the truth in my experience. That's the first thing, okay? I went to prison in 1991 on an armed robbery charge. I was sentenced to 2.5 to 5. In 1987, prior to getting arrested in 1988, I was shot, and I was in the hospital. I was in Bellevue Hospital. It just so happened I was in there for about 6 months. I had gotten healthy enough, and by some strange coincidence, the police came looking for me on a robbery that I had done some months before, and they locked me up. The problem is that I didn't finish my medical care. And so I was scheduled to do something called the spinal tap at the time. And they told me about it, and I was thinking about it because they told me I had to be awake, and they showed me this long needle that they were going to push up along my spine. And I said, "You want me to be awake for this?" And they said, "Yeah." I said, "I need to think about it." In that time, the police came and got me. And I went to Rikers Island, and I was having some troubles, but I didn't go to sick call. And there was 2 reasons why. One is that people need to understand that these systems that we put into place are to deal with human beings. And a lot of these systems are intentionally cruel and inhumane to the people that they are supposed to be serving. So I don't want to go to the doctor where I have to argue with him to get something out of him, where I have to argue with him to get the right care that I needed. So I bypassed him. When I got upstate, I started having more problems. And I went back to the sick call, and they put me in front of a nurse, and I said, look, I was scheduled to take a spinal tap in New York City. I was shot on this date, blah, blah, blah. I did this, I had this done, I had that done. I've got a few screws in the back of my neck or whatever the situation is. And they said, okay, fine, we have to re-examine you. And then if a spinal tap is needed, the doctor will authorize it. You'll be called back down to see the doctor in the next 2 or 3 days. They never called me. 6 months go by. I go back down to sick call again, and I say, look, I'm having troubles, for some strange reason. And they said, well, there's nothing we can do for you right now. You got to get scheduled to see. When I finally did see the doctor, he told me that the spinal tap wouldn't be necessary, and that if I was feeling any more discomfort, I was to just come back down to sick call. After that, I just said, you know what, whatever the situation is, I can deal with it. And it's so funny because when I came out of state prison in 1991, I called up my mother, and I went to the doctor. The doctor told me I had 2 broken toes in my big toe, and told me that I had to do the spinal tap now because they needed to make sure that there was no liquid on my spine or whatever the case may be. And I went and I did it. And while I was waiting to see the doctor, he said, well, why did it take you this long to come and see me about this issue? And I said, well, I was incarcerated. And he said, didn't you tell the doctors and stuff? And I said, yeah, I told them. And they kept scheduling me for a doctor that I didn't get to see for 6 months. And when I finally did see him, he told me I didn't need it. So I just waited, and whatever pain I was going through, I endured it until I came home. I'm thinking about all of the people that have mental health issues, that are HIV positive, that are hepatitis C, and all of these individuals that need to see a doctor on a regular basis. I've got clients that have come to the Fortune Society who have been diagnosed with cancer, who had no treatment until they were released. And when I asked them about it, they said, well, B, when we went to the doctor and we put in all this stuff, they said that, chemo treatment wasn't an option for you. And I said, what do you mean it wasn't an option for you? He said, they told me it wasn't an option for me. What am I going to do, fight with them? I put back on my jacket and I go back to my cell and I sit down. People need to understand that although a person has committed a crime, that individual is not the worst thing that they have ever done. They're still a human being, and they deserve to be treated as such. And don't get me wrong, I have sat across the table from some of the most heinous crimes that people could ever commit. But what I have programmed myself to do is to be non-judgmental about their crime and look at it as a human being sitting in front of me in need. And that's all that's important to me. A lot of the systems that are in place today that I experience with, that my population experiences with, they only go to it because they have no other choice. And they're jaded to social service agencies and the medical agencies that are there to help better their lives. And when people become discouraged with these individuals, they tend not to go and see them. And when they do see them, they're not going to divulge the true essence of their problem because they don't trust you. They don't trust you. And then people that are incarcerated, there's this unwritten myth that's running around. And believe me, I don't think that there's a way that you can break it. But in their mind, everybody that's in the medical staff are only here because they couldn't get jobs in real hospitals. And so, and notice how I said there is a myth going around, because I have come across some truly caring people in the medical field while I was incarcerated. It's not everybody. It's not everybody, but it's that 1 or 2 that you have to constantly come in contact with that are making you feel jaded about this system.
Barry, can I ask you to talk more about how your experiences with medical care inside prison influenced the way you interacted after you got out? You just started to mention that sort of lack of trust, and I wonder now, you're constantly seeing people who are coming out. Is that a common response for people who are recently released?
It is a common response, but they have much more faith in the healthcare system out here than they do while they're incarcerated. When people come out, they actually seek to take care of their medical issues, but a lot of them don't know how to navigate the system. Even the Obamacare, you know, the Affordable Care Act, they don't even know how to navigate that. So what we're finding out is that the agency has to set up little hubs to help them deal with those issues. So we've got a single stop area which helps individuals fill out all those paperwork. We run an Affordable Care Act once a week where we have people come in and sign individuals up. They're buying into the medical care system while they're out here. But part of the problem is that a lot of them have let their illness go for so long because they've been incarcerated for so long. The gentleman that I was talking about that came out with cancer, he didn't really start getting chemotherapy and introducing himself to the medical system until he was released. And this is a gentleman that did 20 some odd years. He was in the prison for 20 some odd years. Had they held this gentleman a few years longer, chemo might not have helped him. And that's the damage that the system does. And some of it, in part, is based on the inmate, because we have these myths in our head that the medical staff are really low on the rung of skills and experience. That's one myth that we have. And then the other one is that to get to the medical care, you have to go through the Department of Corrections. And they can be some very rude people, you know. And I'm only trying to be nice because I'm in front of Vera. If we were in Fortune, you'd get it a different way. But they're not very nice people. And I'll give you an example. If you are suffering from any type of pain, and you walk up to the officer and you say, I need to go to sick call, he may look at you and say, okay, have a seat. I'll put you on the list and I'll call him. And he'll walk away and he won't do anything. Other times you may ask to go see the medical and they'll say, you're too late. Sick call was, you know, you had to sign up for sick call last night. And you're going to say, I wasn't sick last night. I just got sick this morning. Good, then sign the list tonight and you can go tomorrow. So these little nuances that you go through to get to see the medical care discourages you. It really discourages you. And so if you're an individual who needs to see a doctor, who has a serious illness, and you're new to the facility and you've never been there, and you go into a facility and say, yo, you guys, I need to go see the doctor, the first thing they're going to tell you, don't do that, boss. Unless you need to, don't do that. Here's why. And they'll give you some story about the guy that was sleeping in the bed next to you 6 months ago. And so you begin to believe that stuff, and it becomes embedded in your system. So when you get sick or you feel hurt, you're like, man, I just need some aspirin. I'm going to be all right. I'll deal with it. And that's because people don't have faith in the system because of the way that they were treated while they tried to get access to that system and when they did get to that system. So, and again, it's not everybody. It's not every correction officer. It's not every medical worker. It's different. You know, you may have 1 or 2 people in one facility, but if you discourage 10 people to come and get medical assistance when they need it, those 10 people are going to tell 10 more people. And before you know it, no one in the prison is coming to see the medical staff.
I think Dr. Bassett has a question.
Well, no, I was just, I mean, some of the stories that you're describing just sound straightforwardly like negligence. These are just cases of medical negligence. But one issue that keeps coming up about both the jails and the prisons is the whole issue of mental health. And the fact that people who have mental health diagnoses are overrepresented and don't get adequate management, that the whole kind of process of breaking rules and being punished may be fueled also by mental health diagnoses. And can you say anything about that?
Sure.
As you talked a lot about physical health problems.
The Fortune Society recognized this in the 90s when the city closed a lot of mental health clinics, and they said the money would go to CBOs. We still waiting on it. So what happened is in 2010, we opened up the Better Living Center because we recognized that more and more of our population were coming through the door with mild, moderate, and severe mental health issues, and we weren't equipped to deal with them. I have been incarcerated around quite a few mental health individuals. At one point when I was incarcerated on Rikers Island, I thought I could get out early if I played the mental health card. So I was actually in the dorm with them for a while. I tried a few things to get out early. I'm not going to lie. And one of the things that was kind of amazing to me is that there is not enough staff, first of all, to adequately deal with the number of mental health people that are incarcerated. And that's on both levels, city and state. One of the things that happens is a lot of times individuals go undiagnosed. That's the first population. The second kind is the people that are diagnosed but can't get access to the medication because they don't have a prescription with them when they got arrested. So the doctor has to re-examine them again, and medication has to be reissued again, which is understandable. But the wait time between this individual to get to see the psychiatrist to be evaluated, the medication that they were taking while they were on the street leaves their system, and they begin to act out again. Like the good doctor said, obeying rules, regulations, walk on the left, not on the right, simple things to you and I that is very difficult for them to go through. And so what we did at Fortune is we opened up the Better Living Center. But what we noticed, even though we had the Better Living Center open and we were talking with people while they were incarcerated, I had a gentleman who was incarcerated, and we had to get the founder, David Rothenberg, to call up the commissioner because he could not get access to his mental health medication. And this was a gentleman that when his meds left his body, he became deeply depressed. And rightfully so. I mean, his life was in kind of a shambles. And he was arrested. He was put on Rikers Island. And he called up the agency and we said, how are you doing? He said, listen, he said, I'm doing fine with the exception of getting my medication. I went to the psychiatrist and they told me I have to wait for them to do an assessment of me, a diagnosis, and then I will be issued medication. And he said to me on the phone, he said, Barry, I'm slipping. He said, Barry, I'm slipping. And to me, what that meant was a danger sign, because when he was out here in the street slipping, we found him in an office building drinking bleach in the middle of the lobby. They called us up. The building security called us up, and we had to go and try to, they put him in Kings County and everything. So when he said, I'm slipping on Rikers Island, I got scared and I started to panic. I said, well, we got to reach out to somebody and get to him fast because we know how he de-escalates. He decompensates very rapidly. These are just one or two of the stories that individuals have to go through. But what made me think about this young man is that, what if he didn't have us to call? What if he didn't have a Fortune Society number to call? Who does he go to?
Well, one of the things that Liz was talking about, I think, is that asking the question, where can he go instead of Rikers? If somebody... And that is something that we've been talking a lot about, and we're working at the health department, and maybe Liz could say more about it, but we're working on a pilot now to create something that we're calling a drop-in center. It sort of was sparked by that tragic case of the former Marine who was picked up on a trespassing charge and ended up dying at Rikers in an overheated cell. And the question was, where should the police have taken him? Wouldn't it have been good if they could have taken him somewhere else? The choices are usually an emergency department, a homeless shelter, or a jail. And these drop-in centers would be an alternative where someone could go and give you like this space to try and identify a better disposition of someone than sending them to jail. So that's part of the solution, I think, has to be that we have to have fewer people who have mental health diagnoses ending up in jail. If they don't pose a risk to the community, if there are services available, and you mentioned that your organization has some, but so do others. If there are services available, then we would like to see people never going to Rikers in the first place. We would like to see people who are in court being arraigned, who are identified in need of services, being diverted at that point in the pre-arraignment. Even while people are awaiting trial and they already have been incarcerated, there's an opportunity to divert them and take them out of the criminal justice system and put them into into community and into services that can support them with their actual underlying problem, which is not criminal behavior, but a mental health issue. It might even be a substance abuse issue. In other jurisdictions, people with substance abuse disorders have been benefited also from diversion. We have to, you know, it's great that the numbers have gone down from 20,000 to dipping now for the first time under 11,000. That is still staggeringly high compared to all other wealthy nations, as all of you know. We have the number of people in solitary confinement on Rikers today being punished for various infractions exceeds the number of people in solitary confinement in the entire United Kingdom. That's England, Scotland, and Wales. That number of people sitting in solitary at Rikers now. So the numbers are still far too high. So we need to make sure that people don't go there when they shouldn't be there. And one that's relevant to health, obviously, is trying to identify people with mental health diagnoses. There have been other strategies that the administration's been talking about, changing policing practices, changing, you know, I don't know, the arrest for minor drug offenses, that sort of thing.
I just want to point out that this nation has known for a long time that people with substance abuse issues should have been diverted to clinics and outpatient. I say that to say this. There is a movement happening now where people are having discussions about it. We need to move past discussions. There needs to be action taken, because the amount of people that have been incarcerated under the substance abuse issue is outstandingly outrageous. People that need treatment, not incarceration. And here's the other thing that we do. We create some of these issues that we have when people come out. We make people worse off than they were when they went in there because of the system that we put them in. And that's just the truth about it. You know, Joanne Page asked me one time, she said, tell me about that part when you say, if you put me in the jungle, I either have to be the prey or the predator. I'm going to be the prey. If I have to choose, I'm going to be the prey.
The prey? No, you're going to be the predator.
No, excuse me, the predator, not the prey. And I say that to tell people is that whatever environment you put me in, I'm a healthy person mentally, physically, I can adapt to it. What about the people that are not like me? What about the people that can't adjust to things very quickly? What about those individuals, substance abuse issue, you know, he's been using crack cocaine or heroin for the past 30 years, and he finally gets arrested, and he finds himself sitting on Rikers Island. His habit doesn't get any better. If anything, it's going to cost him more because he's buying dope at a higher price in jail.
He's supposed to be going on methadone.
Yeah.
This is I think what Barry and Dr. Bassett have both pointed to is a really fundamental point about specifically with regard to people who have mental health issues and substance abuse issues, and how inappropriate incarceration is for them in many cases, and if not most cases. But I'm interested, before we open it up, I think, to questions from the audience, I would like to hear from David and Liz on this issue of communication when it comes to people who are going to end up incarcerated and still have health issues that need to be addressed, and still have communities they're returning to that will be affected by their incarceration. David used a phrase in the paper, therapeutic jurisprudence. And I was wondering if you could talk about what that means in this context, and if, Liz, you could also address the efforts that are being made to integrate these two systems more effectively throughout the city.
Sure. So it's basically the idea that justice and health systems, other social service sectors are going to work collaboratively. It's kind of a switch away from punishment for the sake of punishment. The basic kind of, it's a different solution to respond to. It's the foundation for like mental health courts, drug courts, and things like that. It's like a problem-solving scenario. So naturally, to achieve those types of things, you have to share information. You have to share sensitive information. You have to develop trust of your adversary, you know, someone who, you know, defense attorneys and prosecutors have to get along with each other. I mean, it's a challenging thing to do. And then on the issue of just communication more generally, I think that there are a couple ways to get there. Some of it is just organizational. Some of it is technological, and I think one of them, the critical ones, is the workforce. We need people who are equipped to understand the range of issues. We need to capitalize on things like community health workers. Folks can get that trust, people who understand the experiences of people who've been through things, and employ them and set them up in different places along the justice continuum. They should be the ones doing enrollment. They should be doing the ones engagement. They should be the ones connecting people going into the system, coming out of the system, and doing the warm handoff. I think that trust issue that he pointed out is just critical. And without a different workforce, which I don't think we have, it's going to be an uphill climb.
Liz, what do you think of that?
So I think, there have been many brave experiments that have even worked. I think we see a big, there's been a big movement in the drug court effort. There have been an array of other kind of therapeutic approaches. But I think, to my mind, the problem is it's still this kind of crazy quilt of specialized boutique-y efforts. And the one thing that I think is the most important thing for us to do is, and I will reveal my bias that I think government can be a force for good, is that, government is the waterway. It's the veins that run through this whole system. But we have to make it work well. So, Mary is exactly right. When the cops came upon James Murdow, he was trespassing at NYCHA. So where do they take him? They know how to arrest him, but they're not necessarily trained to see what they see in front of them or have a place to go. When he shows up in court in front of the district attorney, he has a long rap sheet of warranting for reasons that we can all, imagine. But the DA and the judge are saying, this is not a good bet for somebody who's going to come back to court. And they may be right, but Rikers is the only option, right? So I think that we have to think in a much more systemic way about how we identify who people are early on, how we develop those options, and how we ensure that we match the right services to the right people at the right time. So Vera and a bunch of people in this room have been working for a long time on creating, at one point in the system, a pre-arraignment instrument that would identify the mentally ill, which is, what a great thing. But that is a tiny pilot, right? Not tiny, it's huge. It'll serve thousands of people, it'll be important. It's huge. It's like, huge. Sure. But there are certain things that we actually know pretty well now, and that we should have the courage to bring to scale. And I think one place where we should have the courage to bring things to scale is at that point at pre-arraignment, to identify who people are and to be able to develop the match and to have enough services that are actually able to address those folks. I think the other place where we should have the courage, but we may not have the information yet, is exactly what Mary is talking about, which is, let's back it up to that first contact that the mentally ill might have with a first responder. We know how many emotionally disturbed people the police arrest every year, but there's a wide range of folks who are out there with different degrees of a disease, right? And we just don't know how many contacts the police have with those folks every day. We can see who ends up at Rikers, but we need to understand that better. And I think the pilot that Mary is talking about is sort of one way to begin thinking about some options. I think there are a lot of other ways, but we need to sort of understand better. We need to try these options while we're understanding, but we need to know, how many people are we talking about? What's the range of distress that we have to address? And we also have to have the courage, again, to be able to say, not every person who's mentally ill necessarily gets diverted. sometimes there are people who end up in jail, and then we have to make sure that we have the right kind of services and treatment in jail to address it.
David, you wanted to speak on pre-arraignment?
The pre-arraignment pilot that we're setting up in partnership with the health department is a perfect example of communication, because it's happening, and we're going to do the pilot in the Manhattan Booking Center, and there's something called the pre-arraignment screening unit, which are these small health units that were set up in the 90s over a legal settlement over the conditions of confinement. They were crowded, they were dangerous, a lot of it had to do with tuberculosis risk. They said, we need to do a better job when people are arrested to screen them for their basic health needs. Do we need to send them to the hospital? Was really the main point. Long story short, the health department has recognized for quite some time that process is kind of antiquated, it's paper-based, it's not staffed by clinicians who are necessarily able to make the appropriate clinical decisions in terms of triage. So what we want to do is go in and kind of revamp that process. And we want to get some different clinicians in there, working with Michelle Martel, who's in the audience, to get the electronic health records set up in there, get some accurate clinical information, and then rethink kind of the infrastructure of where things go.
What would that look like for an individual person coming in?
So when they come in, they usually are accompanied by an officer who arrested them. They stand in the hall, they stand on a piece of tape, and usually the screener will just ask you, David, are you sick? And it's a very kind of brief 20-second encounter. We want to make it kind of a two pathways. So we're up against some arrest to arraignment times. We need to keep things flowing. New York City is a busy place. There are important legal things we need to keep going. But at the same time, we want to set up an alternative kind of track for folks that we can identify, collect some information, and then part of this pilot will be to figure out what we do with it. Can we navigate? We're going to have to navigate privacy and consent, and once we do all those things, those things are important and we will do them. But we want to find a method to get it up to social workers who are standing in the working with the defense agencies.
People spend apparently 6, 8
so
hours, so there's
a time cushion. So
that's a good thing.
After their screening,
how it will
right.
work. This is a real pilot, meaning it's a pilot that isn't to do something that we know how to do and we don't have enough money to do more of it.
Part of it's also,
it's to figure out how it's actually going to be done.
Right. And part of it's collecting information about health needs before people are transferred to Rikers so we can expedite medical intake for folks who are going to go there. Because if that information doesn't travel with them, the risk of medical error, the risk of them not getting their medications on time is much greater.
And this pre-arrest idea is also one that we've identified funding from the health department. I don't know whether we'll get any other funding. Sounds like maybe not from what Liz just said.
Saying anything.
Smart.
But we are going to get started on it, and we'll learn from these things. And I think some of these things require proof of concept because they are taking a chance. People really don't really understand that the chance we're taking with people's lives by incarcerating them, that is often not one that is being held in the balance. And the notion is that we're all safer when someone is locked up. But we know that that's not a long enough view, that we have people returning to communities, returning damaged, even if they are returned home without being convicted, which 3/4 of the young people on Rikers Island that will be their experience. They'll go home, but they'll go home changed, and they'll go home with trauma that may be physical trauma, but is more likely to be to be social and emotional trauma, which will stay with them and affect not only them but their families. And so all of these costs have to be taken into the balance. But very often people seem to place their biggest concerns on this notion of will we be safe if we leave these people out there, when these people are out there now.
Right. So. I could ask questions for the rest of the evening, but I want to open it up to the audience to ask questions. Does anyone have any specific things for any of the guests? Sir?
Yes, my name is Dakeem. 53 years old. I'm a child prisoner.
53?
I usually preface what I have to say like that because I'm presently on life parole. I started my time at 16, and that time ran to the age of 40. I was released in 1999 to parole, life parole. The thing that I want to bring out with relation to the public health issue in regards to children that go into your prison system is that children have to survive. They're forced to survive in there. I had to survive. I had to learn to defend myself at all costs. And there's a price to pay for a person who seeks, to sustain their own human dignity. And that's usually confinement. That's usually beat downs. If I was bald, you'd probably see track marks all across my head from the beat downs that I received. And I do believe that the reason why prisoners are treated the way they are treated is because you have a continuing and ongoing system of slavery. And prisoners are treated like slaves. And I discovered early in my time that the 13th Amendment states that anyone convicted of a crime becomes a slave of the state. And I refuse to be treated like a slave. And so, for the most part, in the early years, I spent a lot of time in solitary confinement. And I do believe that the effect that it has had on me is perhaps a form of like post-traumatic stress syndrome, where I find myself jumpy, nervous. Before I go to parole, I get panicked. And I do believe that the only way in which you're going to really transform the system is, for one, not to rely so heavily on prison guards who are representatives of the state. And the state, by definition, is an organ of violence. The only thing they can practice is violence. There's going to be a need for greater community control over those prisons. The community should be there. Recently, just last week, we had a protest outside of the island demanding community control. And our program is re-education, re-socialization, and reintegration. Because we have to understand that there are prevailing and pre-existing socioeconomic conditions in this country that make crime necessary. And I could say for myself that, I've renounced U.S. citizenship on a number of occasions. I've sought refuge in a number of countries, including Cuba. I sought asylum in Cuba. And this was simply because of the abuse that I suffered in your prison system. So I would say that urgently that you people have to get on top of it, because you never know who may be coming out of that, angry, upset. And I'm just glad that I didn't have mental health issues, because I might not have been the nice person, cool and calm that I am now, and only seeking just to be free of abuse and exploitation. But I don't think we can also rely on other, organizations that have other motives, like Fortune and Osborne. They're good organizations, but we need organizations that can actually function outside of their grants. Because what I found with Osborne or RWA, Fortune, is that they turn their backs if it doesn't have anything to do with their grant. So what I'm asking is, if this is not grant motivated, that you implement it without using a grant system that would limit your ability to implement whatever plans it is you're having. Because what happens is once there's a grant attached, that's the motive. So I don't know what the motive of this discussion is, if it's fueled by some grants, but if grants is the only thing that's motivating, then you become an extension of the very system that you claiming that you want to change. So that's just my point, you know. Don't make it a grant-fueled motive, because what happens is that's all that you're concerned with. And when that happens, like I find with Fortune and Osborne and RWA, they do not function outside that grant.
Let me open it up to a few other people here. I think there's raised a lot of really important and good points there, but you have a question?
Just last night, Dr. Homer Venters, who had the privilege and the great honor of working with for a couple of years, received an award for the paper of the year from AJPH because he was able to show a linkage between solitary confinement and mental health and self-harm, and adolescence and self-harm, and all of that was predicated on the use of data. And I think in any industry, you cannot manage what you don't measure and monitor. Right, and then yet when you walk into every single jail, they're decrepit, disgusting, and they have no IT. Right, like there are reams and reams of paper. Just this morning at the Board of Corrections, like Corrections was asked very simple stats, and they're like, we don't have a way of tracking that, and that's just a very honest limitation of the system. And yet oftentimes when we talk about the community standard of care, we're often talking about like medical services. But what industry would you ever run without IT? Like where would you ever go to a bank with a paper ledger? Would you ever who shops online on a catalog anymore, right? We just don't do that anymore. And that is the standard of care, that everything is measured, that everything is monitorable, and that every individual in the system can be held accountable. All of your customer service calls are recorded for quality assurance purposes. And yet in the jails, there's less than 20% of Rikers has cameras, right? And again, there's not an IT system really that's worth speaking of on the security side. What do you guys think about the use of IT to be able to create the fundamental underpinnings of accountability, measurement? A lot of people just want to do good work. They just don't know that they're falling short. I don't think that every corrections officer out there is out there to harm. Many times they don't know. Even the justice system is not able to send people to other alternatives because they don't have the information they need to make that decision. They just have a long rap sheet. But what they don't have is the medical record to help explain why that rap sheet might actually exist.
So why don't we get a
I'd love to
response
hear your thoughts
from
on
some of the panelists?
Can I go?
I'll talk to it. So we think a lot about technology and connectivity. The ability to have an electronic health record, we've said it already today, is critical. But even beyond just being able to get providers to communicate in a single organization. So we're starting to think about greater capacity to link those systems to collections of little community providers and hospitals who are sharing through these clouds of information.
I was talking about on the correction side.
On the correction side.
Let's talk about a record that's up and functioning. What about the correction side?
I know less about corrections.
Who could argue with you? No, so I think it's absolutely critical. I think it's the way in which modern agencies and government have to work. I think it shines a light onto whether you're operating well or not well. I think it's of assistance to the people who are running jails, the people who are in the jails, and it's critical. And more than that, you have to be able to have some connection between what's the information is in the jails and what's coming before and coming afterwards, which are lots of different systems. And we're not good at that yet.
Any other questions? Ma'am, in the glasses?
Hi. I wanted to actually go back to problem-solving courts, and I agree that the point of entry may be too late and there should be more systemic solutions. But something I've been actually thinking about lately is specifically drug courts have gotten a lot of positive accolades, and there's a lot of data surrounding them. And I think in New York State, There are 120 or so drug courts and 28 mental health courts. And that seems really striking to me, first of all, because often there are dual diagnosis issues, right? They're co-occurring disorders, and it seems strange that mental health courts have not expanded at the same rate as drug courts. And I just wonder what your thoughts are about that. And I guess my observation, which may also be a question, is the fact that mental health in general, outside of the prison walls, still has a lot of stigma associated with it, and it's not considered as serious as physical health issues. I've heard someone say, well, you have depression, it's not cancer. They're just not considered equal problems. And I wonder if that just larger societal perspective on mental health has something to do, whereas drug addiction seems more, solvable or targeted, and mental health is just too overwhelming and amorphous and stigmatized. And why you think, I guess specifically why drug courts and drug addiction have, it seems, been treated a lot more than mental health. Anyone?
The part on drug courts and that I can't answer. I don't know who.
I will tell you this much. Between the nonprofit agencies, Osborne, WPA, Fortune Society, Alternative to Incarceration program is the longest running pilot program in the history of pilot programs. Forget about it. To this date, it has not been brought up to spec to service New York City alone. That's the first order of business. Second order of business is, just like all of the other entities, especially with mental health stuff, is that when the budget cuts come around, we shoot to the top of the list because we are formerly incarcerated, we are poor and people of color, so we are the first people on the budget chopping list. Every year, Peggy Arroyo, who's sitting in the front, has to go to battle for a pool of ATI money that Osborne, WPA, and Exodus and all of us fight over. And so you have this same class of people fighting over a small pool of money. Whenever government officials start talking about pilot programs, my underwear shrinks 10 sizes and I begin to sweat. Because, and I know people laugh about it, but it's not a joking matter. Because when you think about all of the people that could have been diverted from the criminal justice system in the first place, if we had things like mental health court up to spec, if we had things like drug court up to spec, if we had things like the ATI programs up to spec, and when you consider about the drop in the criminal justice system, imagine what it would look like if those programs were up to spec. Drug court, mental health court, ATI programs. And so, again, I mentioned it at the beginning of it. I'm not trying to offend anybody, but I am going to tell you the truth. And one of the running things about us is that these programs that have come out, we have the data. We know that if you spend $1 in an ATI program, you save $7 in the criminal justice system. We know this. It's been determined. All the data is there for it. But it still has not been brought up to spec. Now, ask yourself why.
Can I ask a question? Barry, you were earlier talking about the Affordable Care Act. And speaking of resources and speaking of communication between various bodies of government, can any of you speak to what the Affordable Care Act has already achieved or failed to achieve and what it may going forward?
I could speak to its potential. So the Affordable Care Act is the biggest expansion of mental health and substance use treatment and part of U.S. history. We're picking up the challenge from the 1960s to give people benefits we promised 60 years ago. And it's going to affect a lot of people who are involved in the justice system, people who were previously excluded in the 1965 version, young childless adults. What does that mean? That means that we have a bigger opportunity to get folks services. So by the law, the funding is there. Now the challenge is to get the bricks and mortar, get the solution, get the workforce to affect it. And for ATIs and things like that, I think it opens up a huge potential for us to be less dependent on grants and things like that. It's a funding stream through a government program that gives people health care, and we can start to bill for those services and go to our Medicaid offices, build alliances, and go to the feds and say, we want exemptions, we want to cover these services, here are the benefits. And we start to bring other players to the table. Insurance companies, they're going to have an interest, and my beneficiary has been arrested. I know he has chronic disease and a mental illness. he disappears, he's not seeing his care manager, he's off in Rikers Island. Soon they're going to have a vested interest. And I hate to talk about it like that, but that's the nature of those companies, is that they're not going to be happy if someone goes into there and gets exposed to solitary, if they don't get the meds they're supposed to get in, and they don't get handed off in a worse state. So,
well, yeah, we're working to. He's talking about something called medical homes, we're as usual with these big transformations, the devil's in the details, and. When someone is on Rikers Island, their health care is paid for directly. We don't bill Medicaid for the services for somebody on Rikers. So we've been working hard on the discharge planning component. Two people back there can probably tell you more about the pilots that we're doing. We're doing 2 pilots with medical homes, one in Brooklyn, the other is in the Bronx, on trying to ensure that connection works more smoothly. Dr. Parsons, who worked long and hard on trying to ensure that we had automatic access to medical home information, could probably tell all of us a lot about how difficult it is to make these information systems accessible and communicating with each other. But we are doing some pilot programs and agree that it's an opportunity. John, you want to say anything more about those pilots, or?
Yeah, I mean, just in the sense that I think the one thing that often gets lost is the biggest population in the criminal justice system is on community corrections and goes through courts like our Midtown and Bronx Community Solutions. So they're going to court, and they're under some supervision, but they're in the community. And research shows they are actually the highest users of expensive community services and also disconnected. So we also have to focus on that population. And managed care is very interested in them because they're not like off-ramping them to city tax levy dollars.
Right.
They're still on their rolls. So we're doing a lot of work with how do we connect managed care and care coordination to the courts so that they play a role and, to David's point, maybe leverage Medicaid dollars to pay for some services. We're going to have these health and recovery plans, which have enhanced services for those serious mentally ill. And these are really interesting peer crisis services. And this has been done by a guy from Phoenix, and they do this, an officer, they've been doing this for 25 years. New York's way behind the ball on this, so we have a lot to learn, but I think there's a lot of opportunity.
Okay. I think we have time for one more question.
Thank you. I want to congratulate you on putting that pre-arraignment program together for those with mental illness, because I do think it's very important. And I think when you do any kind of research, when you have positive or negative results, it informs your next steps. So hopefully we'll get good positive outcomes from this. In terms of doing something that we know can help those with mental illness, both on the street when the cop's walking his beat and within prisons, is crisis intervention training. I know that this is something we've talked about a lot, but just knowing how to handle emotionally disturbed people can really improve the outcome, whether it's on your neighborhood street or, again, as I said, in jail. Can we just talk about where we are on that? That I don't feel is so much of an experiment. That is more proven to work.
I do it every day on the job. Every day. I will say this much. In the agency, we started a discussion because of the large population of mental health individuals coming into the facility. We put together a crisis intervention team. And one of the most important things when we selected individuals for this crisis intervention team is, do they have the skills to de-escalate a situation, whether it's with someone with mental health issues, substance abuse issues, or someone with behavioral problems. And we identified those individuals through experience in working with these people over years, that these are individuals that can deal with any situation that comes into our agencies. Now, one of the biggest issues that we have is those people that are undiagnosed with mental health issues.
I think it's a treat to be able to have a panel of people who with such a depth and range of experience here. So I just want to ask you to join me in thanking them for taking the time to talk to us.